I had the opportunity during this meeting to really think about therapy in polycythemia vera and how we've really come from not having a lot of therapeutic options or more archaic therapeutic options to a whole host of new options. Um, Agents with novel mechanism, repurposing of older agents, and kind of the whole gamut. So the first part of my talk really focused on the biology of polycythemia vera and how we've really learned more about the disease itself over the course of the past several years. That's really important because it's allowed us to develop therapies based on biology. And so I think it's always more effective, more interesting, and better for patients when we're being smart about therapy development and really using our knowledge about the disease to develop therapies. And so what I discussed in terms of therapies was really the limited options we had until about 5 years ago. We spent some time talking about older agents in the field, so drugs that have been approved for some time. So I think the best examples would be ropeg interferon. And I didn't spend a lot of time in discussing ropeg interferon because there was a lot of discussion and several other talks about the role of interferon and various MPNs at this meeting. Very interesting. I'm a huge advocate and user of interferon-based therapies in my own practice. And so that was really interesting for me to hear. So discussed a little bit about interferon. And then I think some really interesting data is the data looking at ruxolitinib in patients with polycythemia vera. And so Dr. Claire Harrison had a really lovely recent publication, the MAJIC-PV study, looking at use of ruxolitinib in the PV patient population. And I think what was really interesting and lovely about that study was the way that it correlated really interesting and important outcomes like event-free survival, overall survival to molecular responses within polycythemia vera. So this is an up-and-coming topic, and really the first study, or one of the first studies, if not the first study, to make that correlation between molecular responses for patients and these various outcomes measures while still achieving count control, very important, and symptom benefit for patients. So we discussed those agents, which have been approved for some time. And then I spent some time talking about the newer agents and what's coming up into market and some of the exciting studies that are in the field. And so I think just some great examples of that are agents that are really targeting iron metabolism. So we know that patients with polycythemia vera have dysregulated iron metabolism. And hepcidin is a very important regulator of the iron pathways in patients, and they're obviously dysregulated in PV patients. And so the field has started to develop drugs that mimic hepcidin, so hepcidin memetics. They act very similarly to endogenous hepcidin in the hope that these agents will minimize the phlebotomy requirements for patients by, again, altering iron metabolism. And so I discussed a little bit about the phase 2 REVIVE study of an agent called Rusfertide for patients with patients with PV and ongoing phlebotomy requirements, and then some additional agents that are in early phase study, again, targeting the iron metabolism pathway in a slightly different way. And then independent of that, kind of lastly, we talked a little bit about other pathways that have shown to be important in PV and some agents that are up and coming there. So we discussed an LSD1 inhibitor in patients with PV, and then also an HDAC inhibitor. And so I think the conclusion of the talk, and what I say a lot of times when I give these talks, is that the future really is bright for patients with MPNs and PV. Lots of therapies that are being repurposed and not reused, but repurposed and improved upon. And then lots of novel agents coming up the pathway as well.